As far as reassessment of a patient that's bleeding, you want to reassess frequently, especially in areas that show abnormal findings during your primary assessment. So, any signs and symptoms of internal bleeding are often going to be slow to show themselves. And children compensate very, very well. They do really, really great for a while. And then when they no longer compensate, like they nosedive. So keeping a close eye on those patients is necessary. Remember that we reassess unstable patients every 5 minutes, the stable every 15. And then, of course, whenever there's a significant change in your patient, you want to start back over with your primary assessment and vitals because you essentially have a new patient. You want to check all of your interventions, make sure that your O2 is high enough and doing what it needs to for the patient. Don't um, delay transport for your reassessment. This is as we're going toward the hospital. For communication and documentation, you want to recognize, estimate, and report the amount of blood loss and over what period time that it occurred. So if a patient estimates the time of accident or how long it's been, or somebody gives you an estimate, you can guess that they were bleeding over that time period. Sometimes it's really not anything that we can estimate, but just as best as you can, rather than say the patient lost 500 cc's of blood or 500 mils of blood, you can say that there was a blood spot about this big on this clothing, or they soaked this many towels, or if a woman is utilizing feminine products, they've gone through this many pads or tampons. That's often a better estimator of blood loss rather than just trying to say, yeah, they lost this amount. Make sure that you communicate all of your relevant information to the receiving hospital. And oftentimes there are guidelines for when you're going to have a trauma patient, so level 1, level 2 trauma. And you want to communicate that early to the hospital because they need to get different people there to adequately take care of that patient. And they don't want to be calling them as the patient arrives because then they're already behind the 8 ball. And then you'll document all care provided, as well as your patient's response to that care, just like anybody else. For standard precautions, at a bare minimum, you need gloves, more than likely need some eye protection, and then potentially a mask or a gown, kind of depending on what it is. We're going to make sure the patient has an open airway and they're breathing adequately. We may need to make sure that we have our suction with us. We want to provide high flow O2 and then control any life-threatening bleeding as quickly as possible. And there's several methods to do that. Direct pressure dressings, or splints. So you put those in place and you don't have to hold them anymore. And then tourniquets. It used to be back in the day, you didn't put a tourniquet on unless you were creating a line for the surgeon to cut. We found that that's no longer the case. For direct pressure, this is the most effective way to control external bleeding. Most of the time, your bleeding will start with direct pressure. It stops the flow of blood so that normal coagulation patterns can occur. So you want to apply pressure with your gloved fingertip and hand, but you're going to use a sterile dressing to actually press onto the wound. If there's an object that's sticking out of the wound, you want to apply bulky dressings around it to try and stabilize it while applying pressure as best as you can. We don't pull any impaled objects out of wounds unless it's blocking the patient's airway. Then we'll consider what we need to do. If there's nothing like that, you just want to hold uninterrupted pressure on the wound for at least 5 minutes. And there's a skill drill 25-1 for that one. For a pressure dressing, you want to take a sterile self-adhering roller bandage and wrap that around the entire wound. You want to use 4x4 sterile gauze pads for small wounds and the big universal dressings for larger wounds. Make sure that that dressing covers the entirety of the wound, and it should have a little bit of a buffer zone around it so that you don't bleed outside of that dressing. Make sure that you secure the Band-Aid on tight enough that it's actually putting pressure on the wound, but you need to make sure that you can palpate a pulse distally from the dressing. We're not actually applying a tourniquet with this pressure dressing. That's not the point. You want to keep the dressing on until a physician has evaluated the patient. If necessary, if they're bleeding through, just apply additional dressings over top of that first one. We don't really want to remove that first one because it could be possible that blood is clotting to it. And if we were to pull it off, we're basically pulling off the majority of the clot. So for hemostatic agents, this typically isn't something that most field trucks have, but if you do, it's a chemical compound that slows or stops bleeding by assisting with clot formation. There's two different forms. There's granular powder, and then there's like a gauze pad or a dressing that actually has the hemostatic agent built into it. If you are using direct pressure and it's not quite working, you can, with the blessing of your protocols and medical directors, utilize this hemostatic agent to assist you in clotting. Hemostatic agents in civilian EMS is pretty largely experimental right now. The military uses it. They used to have an awful lot of the powder, but it's activated by any sort of liquid. And so people were pouring it into wounds, and then the wind would pick it up and blow it into eyes, and it was causing some pretty nasty chemical burns. So now they mostly use the dressings, which are called chitosan dressings specifically, and those seem to work very well militarily, but they're still super expensive, so they don't use them a ton if they don't have to. They prefer tourniquets. The tourniquet's very useful for anybody that has substantial bleeding from an extremity. Keep in mind, we're not going to be able to get it around the torso. It's not going to make any sense. We're not putting them around the neck ever. So just little common sense. There's tons of different types of tourniquets. Each of them have the same general concept of how to use them. If you don't have a commercially available one, you can create one using a triangular bandage and a stick or rod. A pencil doesn't tend to work because they are soft enough that they break. You have to use something that's not going to break as you tighten that down. As a super last resort, you can use a blood pressure cuff as a tourniquet, but you end up really effectively shutting down blood over a large area. When you're using a makeshift, you have to make sure that whatever material you're using for the tourniquet, not so much for the windlass or the rod that you're going to use to tighten it, but whatever you use has to be about 2 inches in width at a bare minimum. For triangular bandages, they say the ideal is 4 inches, but you don't want to use anything that's too skinny because then you do end up cutting in. So if you use like shoelace, they do not recommend the use of shoelaces because that actually does damage the skin underneath and can actually cut into the skin if you get too carried away. Whenever you're using a tourniquet, there's some precautions. You don't want to apply directly over a joint. You always want to place the tourniquet proximal to the injury. Make sure that it's tightly secured and we're not going to take it off. Never use wire, rope, a belt, or any other narrow material. If worse comes to worst, you got to do what you got to do. But again, no less than 2 inches in width, preferably 4. Never place padding under the tourniquet to protect the tissues. And this just keeps them from pinching as you start tightening whatever you are using down. That skin is going to start to pinch underneath of it, and that can hurt an awful lot. If you put like the shirt or something right there as you're training it down, the shirt's going to be what gets pinched and not so much the skin. We want to make sure that that tourniquet is visible at all times so that people know that they have it, and you want to mark the exact time that it was applied and make sure that you let the hospital or wherever you take the patient know when you put it on and why you put it on. For splints, air splints, these are also known as soft splints or pressure splints, and they can control internal or external bleeding associated with severe extremity injuries. They can immobilize fractures. They act like pressure dressings, but it's applied to an entire extremity rather than just a small area. You want to make sure that you use only approved, clean, or disposable valve stems when orally inflating splints. A lot of them have pumps now, but if not, you want to make sure that thing's clean. For rigid splints, these are going to be more for just immobilizing fractures and reducing pain. It does prevent further damage to soft tissue injuries because those bone ends are no longer cutting around in there. And remember, whenever we apply a splint, we check CMS before and after application. Bleeding from your nose, ears, and mouth definitely presents problems with airway obstruction or aspiration. And there's several different conditions that can result in bleeding from these areas: skull fractures, facial injuries, sinusitis, infections, people that abuse nose sprays because it'll cause things to dry out and crack, high blood pressure, coagulation disorders, and then digital trauma, aka picking their nose. Epistaxis is just a fancy word for a nosebleed. It can be pretty massive though. A lot of people freak out. It occasionally can cause enough blood loss to put a patient into shock, but it doesn't necessarily normally progress that way. You want to pinch the nostrils together and have them lean forward. We don't lean them back anymore because all of that blood goes into their stomach. Stomachs don't like blood, so they end up vomiting. Keep in mind that a lot of the blood that you see coming out of the nose is not the entirety of the blood, so we want to be very careful with that. Bleeding from the nose or ears may indicate a skull fracture, are going to be more difficult to control. Oftentimes we're not going to stop the blood flow. We're just going to apply pressure, light pressure to the head with a sterile gauze pad because we don't actually want to worry about a skull fracture. If we do, we're going to be putting bone right into their head, or into their brain. So we don't want to do that. For internal bleeding, a lot of times it's going to require surgery or other hospital procedures. So a lot of what we're going to do is emotional assurance, keeping them quiet and calm, maintaining body temperature, splint any injured extremity if the patient's condition allows it, and make sure that you're using tourniquets and other materials appropriately. And high flow oxygen, maintain a supine position if the patient will tolerate it. And that's pretty much all we've got for chapter 25.